a man in his late 40s with poorly controlled type 2 diabetes and a history of foot problems. And his doctor is concerned about his feet, especially his left foot. His family has had a history of diabetic foot ulcers and in one case, an amputation. His assessment showed a diminished circulation and lack of protective sensation in the left forefoot. His lunge test and hallux dorsiflexion shows reduced range of motion. Structurally, he has a high arch foot with stiffness through the midfoot and forefoot joints. And the third MTP joint is plantar flexed in relation to the other MTP joints and is prominent. So with people with high risk feet, we want to know a bit more information about the type of weight bearing rather than just the average pressure mapping. So most systems will give you an averaged pressure mapping, a maximum or peak pressure mapping, or a integral or time-based pressure mapping. And this is really important because we need to know exactly how much forces are going where in the foot and for how much time. Because if the pressure is too high, it can obviously overwhelm the tissue. That's pretty straightforward. The integral pressure gives us a period of time where that pressure is loading on the tissue. Now, for a patient with a high risk foot, this is critical because if the pressure is placed or the loading is placed for an extended period of time on that tissue, it'll tend to push the blood away from the tissues and can result in a localized hypoxemia, further damaging the involved tissues. And so we can see these are the views that we can look at. And you can see that the pressure mapping is slightly different in each of the views. And that's because the average pressure is looking at the peak pressure and the ground reaction force as an average. The maximum pressure is just looking at the peak pressure, and the integral pressure is looking at how long it's been there. So if we have a look at the data acquisition of this patient, we can see that on the left foot, the peak pressure line in red, and it's maybe hard to see, travels directly from the heel to the third MTP joint and remains there until the foot is lifting, indicating that the highest tissue load is being placed on that area. In comparison, the peak pressure of the right foot travels from the heel onto the first MTP joint, with the center of pressure going through the second and third MTP joint, thus loading more tissues, spreading the loading as the weight travels through the forefoot. This is absolutely key to the risk status in the tissue loading of our area of concern. So looking at as a integral pressure now, so we're looking at the timing of the pressure, we can see that the pressure that the tissue is loading is there for almost, in fact, it's more than half of the stance period of that person's gait. That is reducing the oxygen and nutrients in that tissue, as well as overloading the tissue. Now we have to think about this in a repetitive nature of gait. 4,000 times a day, this situation creates circumstances where only a small increase of pressure may cause a significant injury and ulcer. It might be different shoes, it might be going on a holiday, it might be the foot is swollen, what have you. This person is at a high risk of a major injury. So once we've analysed the data, we need now to assess how best we can change the peak pressure and the integral timings underneath that area at risk to prevent injury, or at least help the tissues of a current injury heal. So it may be that the person does have an ulcer, or it may be that they're at risk of having an ulcer, or perhaps they have had an ulcer and they've been discharged from the ulcer clinic, and now we need to do something to prevent them having an ulcer in the future. Either way, plantar pressure analysis of this is incredibly easy and very effective. What we need to do is apply a felt pad under the area to redistribute weight. Then have the patient walk over the mat again and review the effect under the area at risk, getting that objective key data so that we can design a pressure relieving insole. Now, the studies show that we need to reduce that pressure to approximately 2 kilograms per centimetre squared for the tissue to completely rehabilitate and become solid again. So we can put on a felt pad like you've seen there, or another different design, review it and look at the peak pressure and actually look at the numbers, going to the numerical listing and saying, okay, is this much less? Are we getting under 2 kilograms per centimetre squared? And then go to the integral pressure and see if we can share the weight bearing. Now, we might do that by combining the pressure relieving insole with shoes like runners that have a high toe spring to alter the timing of the tissue loading. We might also put a soft heel lift to get more weight bearing into the heel to reduce the time on the forefoot. Overall, we need to put an intervention in place, then review it, then have the patient go away in day-to-day activity, then have them come back and review them again to actually see if what we're doing is making a significant effect. In doing this, we reduce the risk of injury, we reduce the injury of ulceration and amputation and all of the bad things that go on with that.